Hello guys, today we are going to discuss about the management of pain after the extraction. So this case is about a person who undergoes extraction but still no signs of relief. So let's begin.
Summary. A 36-year-old lady presents with severe pain a few days after tooth extraction. What is the cause, and what can be done? History. Complaint. The patient complains of a distressingly severe pain in an extraction socket on the left side of her mandible. The pain is localized to the extraction socket and is not sensitive to hot or cold. It is a constant, dull, boring pain, unrelieved by aspirin or paracetamol preparations. It prevents the patient from performing any normal activity, and it kept her awake last night. History of complaint. The patient underwent surgical removal of the lower left third molar tooth at her dentist 4 days ago. The extraction had proved more difficult than expected and involved repeated attempts at elevation and a small amount of bone removal with the use of a burr. After the extraction, bleeding had stopped normally. The extraction site had been tender but apparently was healing slowly until the pain started yesterday. Since then, the patient has also noticed halitosis and a bad taste in her mouth. Medical history. The patient is otherwise fit and well. She is taking an oral contraceptive, and no other positive findings were revealed by the medical history. Examination. Extraoral examination. The patient has moderate extraoral swelling of the facial soft tissues overlying the extraction socket and some early discoloration of the skin as a result of ecchymosis. There is trismus, and she is able to open her mouth to only 22 mm interincisal clearance. There are no palpable lymph nodes in the deep cervical chain or submandibular triangle. Intraoral examination. Halitosis is noticeable. The lower left third molar socket contains no tissue, only food debris. The surrounding soft tissues are slightly swollen but not significantly inflamed as judged by the redness. Diagnosis. On the basis of what you know already, what is the most likely diagnosis? The diagnosis is most likely to be dry socket alveolar osteitis. The history of severe and persistent pain localized to the tooth socket appearing 3 to 5 days after extraction, particularly a traumatic one, is characteristic. The lack of local inflammation or enlarged lymph nodes is compatible with this diagnosis and argues against post-extraction infection either in bone or soft tissue. The diagnosis is confirmed by the examination, which shows that the blood clot has disappeared from the socket. In severe cases, the bone of the socket may be exposed, and the bone of the distal lip of the socket can be seen. Halitosis is the result of food debris in the socket being degraded by partially anaerobic bacterial flora. The trismus is almost certainly related to the surgical trauma of extraction. After extraction, what other causes of post-extraction pain are there? Are they likely in this case? Pain from surgical trauma to tissues should be considered when extraction is difficult. However, pain starts immediately after sensation is regained in the area and responds to analgesics. Tenderness is characteristic, rather than spontaneous pain. Osteomyelitis is rare but should be considered because of its severity and difficulty of treatment, especially if diagnosed late. It causes a deep, boring pain, not dissimilar from dry socket, but is poorly localized. Osteomyelitis is almost exclusively seen in patients who are immunocompromised or have sclerosis of the jaw bones. It usually takes several weeks to become evident. Osteoradionecrosis is rare and only associated with previous radiotherapy in the field of surgery. Medication-related osteonecrosis (MRONJ) resulting in persistent symptoms should be considered if the patient has a history of osteoporosis treated with oral bisphosphonates or metastatic cancer treated with intravenous bisphosphonates or antiangiogenic agents. However, this is not the case here. Fractured mandible is a very rare complication of extraction. It might be considered if swelling and bruising appeared out of proportion to dental extraction. Fracture is usually evident clinically if it is displaced. Retained root fragments are surprisingly rarely a cause of long-term pain, although the surgical trauma of the failed extraction may cause pain. Root fragments are almost never found in dry socket. None of these alternative causes matches the patient's symptoms or signs as well as dry socket. What investigations would you carry out? At this stage, the history and examination are completely compatible with the diagnosis, and no investigations are indicated. If there were features of infection, culture of pus and antibiotic sensitivity would be necessary and the temperature would have to be taken. Radiographs are not useful unless a root fragment is suspected but cannot be seen or palpated. Even if osteomyelitis is suspected, radiographs would not provide useful information because there has been insufficient time for the characteristic radiographic changes to develop. What is dry socket? Dry socket results when blood clot in the socket is lost before it can become stabilized by ingrowth of granulation tissue. The exposed bone surface becomes colonized by anaerobic bacteria and spirochetes and is partially and superficially devitalized. Loss of blood clot is thought to be the result of excessive fibrinolysis caused by bacterial, local tissue or salivary factors. In the absence of a blood clot, healing is delayed because soft tissue must grow from the gingival margin to cover bone and fill the socket. How would you treat this patient? Reassure the patient that although extremely painful, this condition does not signify any serious consequence of the extraction. Inform her that the socket will heal normally but more slowly than usual and that during the healing period, treatment can be provided to relieve the pain, although she may have to return for several sessions of treatment. Local treatment to the socket is the most effective measure. Irrigate the socket gently with warm saline. Place a dressing into the mouth of the socket to prevent further impaction of food. Many proprietary dressings are available, including resorbable materials, antiseptic preparations and analgesic formulations. In practice, almost all are satisfactory, provided they are used appropriately and replaced as required. Care should be taken not to pack the socket too much with the dressing because this would prevent it from filling up with granulation tissue as healing progresses. Effective socket cleansing and socket hygiene are more important than the type of dressing used, and the patient should come back every 2 days for retreatment, if necessary. In severe cases, a daily dressing may be appropriate initially, and as the socket heals and pain is reduced, the period between dressings may be extended. The trismus should be monitored and should reduce. What drugs might you prescribe? Antibiotics should not be prescribed because they are ineffective. Analgesics are also largely ineffective in the absence of local measures. A nonsteroidal anti-inflammatory drug should be adequate in most cases. The pain of dry socket is notorious for its severity, and in the past, controlled drugs have been prescribed. This is only occasionally justified but may need to be considered. How quickly will the pain be relieved? Improvement of symptoms will usually be noted within minutes or in up to an hour and more quickly if the dressing contains a local anesthetic agent. Pain may start again. Risk factors for dry socket. Surgical or traumatic extraction, mandibular extraction, especially third molar, female gender, especially if patient is on contraceptive medication, smoking, infection or recent infection at site, periodontal disease or acute necrotizing ulcerative gingivitis elsewhere in the mouth, local bone disease or sclerosis reducing blood supply for clot formation, as in Paget's disease, cemento-osseous dysplasia or after radiotherapy. Excessive use of local anesthetic, vasoconstrictor in excess around the socket may prevent formation of blood clot. History of previous dry socket. Being young adult or middle-aged patient a day or two after dressing. Gradually increasing in severity. After a few days, the pain will reduce and redressing may not be necessary. After about 10 days, the socket should be filled with tissue, and it will probably be asymptomatic for the last few days of healing. What if the condition persists for longer than this or appears to be worsening? Failure to resolve in the longer term usually indicates the presence of small sequestra of devitalized lamina dura or root fragments. These are normal sequelae of extraction and are usually resorbed in the remodeling process during healing. Larger pieces may delay healing and sometimes sequestrate through the alveolar ridge mucosa many weeks after extraction, although they are not usually associated with significant pain. Occasionally, larger sequestra of lamina dura may be seen on periapical radiographs. If the sequestra are associated with symptoms and are not shed, surgical removal may become necessary. In practice, this intervention is extremely rarely required, and sequestra are usually small and lost without being noticed. The diagnosis will have to be reviewed, and radiographs are also useful to exclude other causes for the pain. The possibility of osteomyelitis should be considered and thoroughly investigated if the nature of the pain has changed or if the patient suffers any condition predisposing to this condition: local bone sclerosis, pathological or therapeutic immunosuppression, bisphosphonate drugs.